I'm Dr. Gregory McHugh, a clinical assistant professor in the Department of Anesthesiology at the University of Pittsburgh Medical Center, and we're going to talk about general concepts in pharmacology under the heading of basic topics in anesthesiology. I have nothing to disclose. First, we'll start off with two definitions. The first is pharmacokinetics, which describes the absorption, distribution, metabolism, and excretion of drugs. Simply put, this is what the body does to the drug. And then pharmacodynamics, which describes the response of receptors to drugs and the mechanism by which these drugs exert their clinical effect. And then this is what the drug does to the body. The majority of this lecture today will be focused on the pharmacokinetic parameters that you see described here. So we'll start with absorption and distribution. Absorption is the rate at which a drug leaves its site of administration. This can be through simple diffusion, facilitated diffusion, or an energy-requiring process such as active transport. A similar term is bioavailability, which is the fraction of the administered dose that reaches the systemic circulation. There are a number of factors that affect how completely a drug is absorbed and thus its bioavailability. The first is the route of administration. An intravenously administered drug has a very predictable absorption and is nearly 100% bioavailable. That is, the entire dose reaches the systemic circulation. On the other hand, drugs that are administered by mouth, rectally, or intramuscularly have much less predictable absorption and thus a decrease in their bioavailability. This is often because these routes of administration depend on local blood flow. Additionally, drugs that are administered by mouth are subject to what's termed the first pass effect. In other words, these drugs are absorbed by the gastrointestinal tract into the portal circulation and reach the liver, where they're metabolized before they ever see the systemic circulation. Finally, we have inhalationally administered drugs. The absorption of these drugs is slightly more predictable because of the large surface area of the alveolar capillary unit. However, it's not quite as predictable and it doesn't have quite 100% bioavailability when compared to intravenously administered drugs. Other things that affect absorption are size, ionization, and lipophilicity. So smaller molecules, non-ionized drugs, and lipid-soluble drugs are much more easily and more rapidly absorbed as opposed to larger ionized or hydrophilic drugs. Now we'll talk about distribution. Once the drug is absorbed, it must be distributed throughout the body to its site of effect. And the term here is volume of distribution. This is the apparent or theoretical volume into which a drug is distributed. It's termed theoretical because the volume of distribution may be many, many more liters than the actual plasma volume. This can be quantified by dividing the initial dose of drug administered by the initial concentration of drug in the plasma. And volume of distribution is dependent on a number of factors, the first being organ perfusion. If we look at this chart, we can see that the body can be broken down into several tissue compartments based on the amount of cardiac output that each compartment receives. As you can see, the vessel-rich group comprises only 10% of the body mass, but yet receives 3/4 of the cardiac output. The muscle, fat, and vessel-poor groups, on the other hand, comprise a much larger percentage of body mass and receive a proportionally less amount of cardiac output. So as you can imagine, the drugs that we administer intravenously are going to be distributed preferentially, at least at first, to this vessel-rich group, that is the brain, heart, liver, and kidneys. Other factors affecting distribution are ionization. Molecules can acquire a positive or negative charge by gaining or losing electrons in the form of a hydrogen atom in the plasma. This depends on the drug's pKa and the pH of its environment, that is, the plasma. The drug's pKa is the pH value at which 50% of the drug exists as an ionized fraction and 50% exists as an unionized fraction. It is the unionized fraction, or the uncharged form, that is free to cross biological membranes and thus has a larger volume of distribution. The ionized fraction is confined to the plasma and has a lower volume of distribution. Protein binding also has a very profound effect on how drugs are distributed. Drugs can circulate in the plasma as either a free fraction or a fraction that is bound to protein. It is the unbound drug or free fraction that is able to cross biological membranes and reach their sites of effect, and thus they have a larger volume of distribution. Bound drug, on the other hand, is confined to the plasma. There are two main proteins in the plasma that bind drugs. The first is albumin, which binds acidic drugs, such as barbiturates, and the other is alpha-1 acid glycoprotein, which bind basic drugs, such as local anesthetics and opioids. Lipid solubility also has an impact on the volume of distribution of drugs. Lipophilic drugs are much more easily able to traverse the lipid bilayer of most biological membranes and thus have a large volume of distribution. Hydrophilic drugs, on the other hand, are mostly confined to the plasma. And then finally, we have partition coefficients. These are really clinically applicable to the inhaled anesthetics and will be discussed in more detail in another lecture. However, the partition coefficients is the ratio reflecting how a drug distributes itself between two phases of matter when at equilibrium. And in essence, this reflects the solubility differences of our inhaled anesthetics between air, blood, and tissues, which are mostly comprised of fat. So to summarize, drugs with low volumes of distribution are often characterized as ionized, with high levels of protein binding, and are hydrophilic. These drugs are oftentimes confined to the plasma, and a good example of this are our neuromuscular blocking drugs. Drugs with higher volumes of distribution are unionized, have lower levels of protein binding, and are lipophilic. These drugs are able to leave the plasma and bind to tissues at their site of effect. Examples are propofol, benzodiazepines, and fentanyl. When we talk about distribution, we need to introduce the topic of compartment models. So we think of the body as one single compartment in which the drug distributes instantly and homogeneously throughout the body. This is a very simplistic way of thinking about it and not very clinically relevant or applicable. However, if we separate the body into two compartments, that is, the plasma and vessel-rich group, or the central compartment, and the muscle, fat, and vessel-poor group, or the peripheral compartment, we can see from this picture that the drug can redistribute itself from the central compartment to the peripheral compartment, and eventually reaching an equilibrium. And it is this redistribution which I want to talk about. This is delivery of drug from the vessel-rich group to the less well-perfused tissues such as muscle, fat, skin, and the vessel-poor group. In other words, the drug is redistributed from the central to the peripheral compartment. And it is this redistribution which is responsible for the termination of clinical effect after a single or bolus dose. For example, we give an induction dose of propofol. Propofol immediately reaches the plasma and very rapidly equilibrates with the brain, which is part of the vessel-rich group. The patient falls asleep. Now, once the levels in the brain become high enough, the drug begins to redistribute back out of the brain and into the muscle and fat and vessel-poor group. It is after this that the patient wakes up. Now, if the less well-perfused tissues become saturated because of repeat dosing or continuous dosing, then the termination of clinical effect will become much more dependent on drug metabolism and excretion rather than redistribution. Now we're going to talk a little bit more about the termination of action of drugs. And we'll start with metabolism, which is the biotransformation of a pharmacologically active lipid-soluble drug into an inactive water-soluble metabolite. This occurs mainly in the liver, but can also occur in the kidneys, lungs, GI tract, and plasma with our esterases and pseudocholinesterases. Now, for some drugs, the metabolism actually converts an inactive prodrug into an active metabolite, examples being codeine and enalapril. However, this is the exception rather than the rule. And metabolism typically occurs through phase 1 and or phase 2 reactions by the cytochrome P450 enzyme system in the smooth endoplasmic reticulum of hepatocytes. Phase 1 reactions are oftentimes oxidation, reduction, or hydrolysis reactions and convert a parent drug into a polar metabolite. Phase 2 reactions conjugate that phase 1 metabolite or the parent drug with an endogenous substrate, typically glucuronic acid. The end result is a polar metabolite that's able to be easily excreted. So, metabolism, the goal of metabolism, is to increase the polarity and hydrophilicity, resulting in a lower volume of distribution, confinement of the drug to the plasma, and enhanced excretion. And when we talk about excretion, what we're talking about is removing the drug or the metabolite completely from the body. And the term here is clearance, which is the volume of plasma that's completely cleared of a drug per unit time, often expressed in milliliters or liters per minute. Now, excretion occurs principally in the kidney, but can also occur in the liver through excretion into the bile, lungs, and intestines. Now, renal clearance can be passive through passive glomerular filtration, passive diffusion from the peritubular vascular network into the renal tubules, or through active tubular secretion into the renal tubular lumen. Nevertheless, drugs that are not protein-bound, whether they're unionized or ionized, hydrophilic or lipophilic, are freely filtered at the renal glomerulus, but it is the lipophilic unionized drugs that are absorbed by the tubules back into the systemic circulation, whereas the hydrophilic ionized drugs are trapped in the tubules and excreted into the urine. A more clinically useful way to describe metabolism and excretion is the term elimination. This is the amount of drug removed per unit time, and it often is described in terms of half-life, which is the time necessary for the plasma concentration of drug to decrease by 50%. And when we talk about elimination, we need to introduce the concept of exponential models, and we're going to go back to our compartment models to do this. So if we imagine the body again as one compartment, where the drug is administered and distributes instantly and homogeneously throughout that compartment. The only way for the plasma concentration in this model to decrease is by elimination. and through logarithmic analyses, we found that the half-life in this model is directly proportional to the volume of distribution and inversely proportional to the clearance. Now, if we look at the two-compartment model, the plasma concentration can decrease in two ways, through elimination, but also through redistribution. And we'll come back to our figure here. As we can see, a dose of drug is administered. It reaches the central compartment. From this compartment, the plasma concentration can decrease through elimination or through redistribution to the peripheral compartment. So what we end up with is two distinct phases of elimination. The first is the distribution or alpha elimination half-life. This is the initial rapid decline in plasma concentration, which is due to distribution of the drug from the central compartment to the peripheral compartment. The other phase is the elimination half-life, or the beta elimination half-life. This is the slower decline in plasma concentration, and this is due to true metabolism and excretion. And when we use the term half-life clinically, what we're often referring to is this beta elimination half-life. So if we look at the graph here, and we look on the x-axis and the time after injection, there's initially a very rapid decrease in the plasma concentration. This is due to the distribution phase, and the slope of this line is the alpha elimination half-life. There's then a much slower, steadier decrease in the plasma concentration. This is due to true metabolism and excretion, and the slope of this line is the beta elimination half-life. So to summarize, the termination of clinical effect is often due to the alpha elimination half-life. When we talk about the beta or true elimination half-life, we usually need about 5 half-lives to completely eliminate the drug from the body. Now, it's important to know that most of the drugs that we use in anesthetic practice follow what's termed first-order kinetics, in which a constant fraction of drug is eliminated, and thus their elimination half-lives are fairly independent of their plasma concentrations. However, some drugs follow zero-order kinetics, where a constant amount of drug is eliminated. Example of this is ethanol. And for these drugs, the elimination half-life depends on plasma concentration and is a bit more difficult to quantify. A final term we'll introduce is the term context-sensitive half-life. Now, this is the time for a drug to decrease to a predetermined level or percentage after discontinuing a continuous infusion. And the context here is the duration of the infusion. So typically, the context-sensitive half-life will increase in parallel with the duration of the infusion. If we look at this graph here, we see a number of our anesthetic drugs plotted as context-sensitive half-time as it relates to the infusion duration. If we look at the yellow line, which is propofol, we can see there's a fairly linear and predictable context-sensitive half-time increase as the infusion duration increases. Other drugs, such as fentanyl, have portions of the graph that are linear, but portions that are exponential, and thus calculating the context-sensitive half-time may not be quite as reliable. Because elimination is so dependent on the liver and kidneys, it's useful to talk about what happens if these organs are diseased. In patients with renal disease, they often have impaired free water clearance and increases in their plasma volume. This increases their volume of distribution and necessarily increases the beta elimination half-life. They also have lower levels of GFR and decreases in tubular function, and thus decreases in their clearance, and again, by necessity, an increase in their elimination half-life. Additionally, patients with renal disease often have lower levels of plasma protein because of spillage into the urine, which can increase the free fraction of drugs in the plasma, and thus leading to a possible relative overdose of drug. These patients are also usually acidotic, which can alter the ratio of ionized to unionized drug, and thus profoundly affect a drug's pharmacokinetics. In patients with hepatic disease, these patients have decreases in microsomal function, which decreases the clearance and increases their beta elimination half-life. These patients can also have ascites, which can increase the volume of distribution of certain drugs and increase their elimination half-life. And also they have decreases in plasma protein, particularly albumin, which can increase the free fraction of drug. Now we're going to switch gears and talk about drug interactions. The first drug interactions we'll talk about are enzyme induction and inhibition. And the CYP450 system has a very broad substrate specificity and has constitutive and inducible components. This means that these enzymes are able to increase or decrease their metabolic activity in accordance with substrate exposure. So in enzyme induction, exposure to one drug increases CYP enzyme number and activity, which leads to increased metabolism and elimination of a second drug. For example, anti-seizure medications, particularly phenytoin, can increase the metabolism of our non-depolarizing neuromuscular blocking drugs and thus increase their dosing requirements under general anesthesia. Barbiturates also can induce multiple sets of CYP families and affect pharmacokinetics of a number of different drugs. Enzyme inhibition, on the other hand, because these enzymes have a very broad substrate specificity, the drugs may actually compete for binding sites on the same CYP enzyme. An example of this is cimetidine, which inhibits the metabolism of multiple drugs that we use, including meperidine and propranolol. Other ways that drugs can interact is by their effects on hepatic blood flow. Now, the hepatic clearance of drugs can be thought of as a function of two independent variables, hepatic blood flow and the extraction ratio. This is the ability to extract the drug from the blood and then metabolize it. The extraction ratio can be thought of as the intrinsic hepatic clearance. Now, for drugs with high extraction ratios, the liver is rapidly able to take them up from the plasma and metabolize them. An example of this is lidocaine. The elimination of these drugs becomes thus directly proportional to hepatic blood flow, and alterations in hepatic blood flow can have profound effects on the elimination pharmacokinetics of these drugs. For drugs with lower extraction ratios, such as methadone, the rate-limiting step in their elimination is oftentimes the intrinsic hepatic clearance, and so the elimination is thus independent of hepatic blood flow and much more and can become altered in disease states. Now, some drugs can decrease the hepatic blood flow and therefore alter elimination profiles of drugs with high extraction ratios. Cimetidine, again, which is an H2 or histamine type 2 receptor antagonist, can decrease the hepatic arterial and portal venous blood flow and thus affect the elimination pharmacokinetics of certain drugs. Halothane, also through its decrease in cardiac output, will decrease hepatic artery blood flow and again decrease the elimination of drugs with high extraction ratios. Now, there are alternative and herbal drugs that can interact with many of the drugs that we use in anesthetic practice and can have profound perioperative implications. Ephedra, which is in a class of weight loss drugs, can potentiate many of the sympathomimetics we use in anesthesia, resulting in high blood pressure, MIs, cerebrovascular accidents, and arrhythmias. The drugs garlic, ginger, ginkgo, and ginseng can all inhibit platelet function and can lead to increases in perioperative bleeding, particularly when combined with other platelet inhibitors such as Toradol. Kava or valerian root, which are over-the-counter anxiolytic drugs, can potentiate many of our GABA mimetic drugs and lead to possible oversedation or delayed emergence from anesthesia. St. John's wort, which is used as a herbal antidepressant, induces multiple enzymes, particularly the CYP3A4 enzyme system, and can increase the metabolism of many drugs such as digoxin, warfarin, and antiepileptics. And finally, echinacea, which is used in cold prevention. This can inhibit and induce multiple CYP enzymes and also is hepatotoxic. Now we'll talk a little bit about drug reactions. The first drug reaction we'll talk about is the anaphylactic drug reaction. This is when an antigen binds to IgE on the surface of a mast cell or basophil, leading to degranulation and systemic release of many mediators such as histamine, leukotrienes, prostaglandins, and kinins. This gives the typical clinical presentation of hypotension, tachycardia, bronchospasm, hives. Now, an anaphylactoid reaction is clinically very similar, in fact, can be indistinguishable from an anaphylactic reaction. But in this type of reaction, it is the antigen itself that directly causes degranulation of mast cells. There is not IgE involved. Certain drugs, such as antibiotics, basic drugs, such as morphine and meperidine, hyperosmolar drugs, and our benzoyl-quinolone neuromuscular blocking drugs can have these types of reactions. And then finally, we have idiosyncratic drug reactions. These are more commonly termed adverse reactions. And these reactions are seemingly unrelated to the pharmacological properties of the drug. Examples of idiosyncratic or adverse reactions are rashes, jaundice, anemia, leukopenia, renal damage, and nerve injury. These are more rare, and there really is no direct dose-response relationship that we have identified for these. And the proposed mechanism for these reactions is reactive metabolites. In essence, the drug is administered, it is metabolized, and the metabolites bind to native proteins and then induce an immunologic response. Two final drug reactions are tolerance and tachyphylaxis, which are similar. Tolerance is an increasing dose of drug that's required to achieve the same desired effect. In essence, this is a rightward shift of our dose-response curve. These reactions are reversible, are dependent on the dose and frequency of exposure to the drug, and are extremely variable in their time course and extent. Proposed mechanisms of tolerance include enzyme induction, resulting in increased metabolism of the drug, receptor desensitization, receptor downregulation, or receptor uncoupling from the second messenger systems. Drugs that we use in anesthesia practice which may lead to tolerance are opioids and benzodiazepines. A similar term is tachyphylaxis, which is decreasing responsiveness to a drug after very short and repeated dosing intervals. A good example of this are the adrenergic agonists. These may become less effective after repeated, frequent dosing because of receptor downregulation or depletion of norepinephrine. This is a dose-response curve, and this just illustrates the concept of tolerance. If we start a patient on a particular drug, their dose-response curve initially may be the curve exhibited by A. in which a particular dose will have a particular effect. Now, however, if the patient continues to take this drug over a long period of time, if the dose of the drug is increased, or if the frequency of administration is increased, the patient's dose response curve might shift to B, where a larger dose is needed to produce the same effect. The final topic we'll talk about are the pharmacokinetics of neuraxial drug administration. And we're going to talk about epidural and intrathecal administration. And we're going to stick to the absorption, distribution, metabolism, and excretion paradigm that we talked about for systemically administered drugs. For epidurally administered drugs, for absorption, the drug is deposited directly around the spinal nerve roots, so there's not a whole lot of absorption that takes place. However, the drugs must still penetrate neural tissue, such as the nerve sheath and meninges, and this happens through simple diffusion. And it is the smaller, lipophilic, unionized drugs which are much more able and readily cross these neural tissues, as opposed to the larger, hydrophilic, or ionized drugs. When we talk about distribution, there are two different ways that a drug can distribute in the epidural space. The first, and the majority of the drugs, are taken up by neural tissue and epidural fat. A much smaller proportion of these drugs can actually diffuse across the meninges and into the CSF. Because the drug is taken up by the ubiquitous epidural fat, this necessitates larger doses in the epidural space versus intrathecal administration. Lipophilic drugs, whether it's local anesthetics or opioids, are extremely readily sequestered in the epidural fat. This leads to decreases in bioavailability because less drug is available to be taken up by neural tissue, decreases in CSF concentrations, but increases in the epidural volume of distribution and elimination half-life, because these drugs can actually redistribute back into the epidural space and to the neural tissue. For metabolism and excretion, the drugs are actually cleared by the epidural veins and undergo systemic metabolism and excretion as described earlier. However, it is the lipophilic drugs that are much more easily able to traverse the vascular walls and are more easily cleared. When we talk about intrathecal or subarachnoid administration, in terms of absorption, again, the drug is deposited directly into the CSF. It only has to penetrate the pia mater through simple diffusion to reach its site of effect. And again, it's the smaller, lipophilic, unionized drugs that are much more able to readily cross the pia mater and reach their site of effect. In terms of distribution, the drug has two paths that it can take. Again, it can be taken up by neural tissue and partitioned into the aqueous CSF, or, and this is a much smaller percentage, some can diffuse back across the meninges into the epidural fat. Now here it is the hydrophilic drugs that have the greater spread through via the aqueous CSF circulation versus the lipophilic drugs, which corresponds to a much larger volume of distribution and elimination half-life. A good example is intrathecal morphine. Because morphine is hydrophilic, it can have greater spread in the CSF, it can actually have quite a bit more rostral spread versus intrathecal fentanyl, and lasts and has a much longer elimination half-life as compared to a lipophilic drug such as fentanyl. And again, metabolism and excretion. The drug must be cleared by the spinal arteries or the epidural veins and undergo systemic metabolism and excretion as described earlier. But however, it is the lipophilic drugs, again, that are much more easily able to traverse the vascular walls and are more easily cleared.